Knox County, Tennessee has linked 16 overdose deaths to a drug most Americans never heard of. It's called cyclorophene, the street name for propionitrile and it's a synthetic opioid that experts say is approximately 10 times more potent than fentanyl, 10 times more potent than the drug that has already killed more than 80,000 Americans per year for the past several years. 10 times more potent than the substance that became the deadliest drug crisis in American history. A drug that potent, entering a population of users who have no information about what they are taking or how much of it is in whatever they purchased, is not a public health concern. It's a weapon. Kentucky is reporting an increase in fatal overdoses linked to the same drug. A Nashville laboratory, Aegis Sciences Corporation, has confirmed it's present in Middle Tennessee, not just in the eastern parts of the state where the Knox County deaths were recorded. The Tennessee Bureau of Investigation's Drug Investigation Division is working with local law enforcement to identify the supplier. The Metro Nashville Public Health Department does not currently test for cyclorophene. Dr. Josh Schrecker, the Clinical Affairs Senior Director at Aegis Sciences Corporation, told me that cyclorophene is a highly potent opioid from a highly potent class entering the market. He said it's unlikely to be manufactured in the United States. It is almost certainly being manufactured abroad in countries where it's not illegal and imported here. He said when they see it, it's almost always in a complex mixture of other drugs, and that is where the real risk is, because the person who bought whatever they bought has little or no information about what is actually in it or how much. Narcan can reverse a cyclorophene overdose, but because the drug is so new, nobody yet knows how many doses it takes.
Courage, compassion, faith, freedom, truth. Welcome to Courage in the Darkness with your host, Philip Roberts. It's time to awaken America.
To understand why cyclorophene is generating the level of alarm that it is among toxicologists and public health professionals who track emerging drug threats, you have to understand the trajectory of the synthetic opioid crisis of where cyclorophene sits on that curve. The opioid crisis in America began with prescription painkillers, Oxycontin, Vicodin, Percocet, legally manufactured, aggressively marketed, and prescribed at volumes that created a generation of dependent patients who, when prescriptions became harder to obtain, migrated to heroin as a cheaper and more accessible alternative. That migration was the first transition. The second transition happened when cartels and foreign manufacturers introduced fentanyl into the heroin supply, a synthetic opioid 50 to 100 times more potent than morphine. Cheap to produce, easy to transport because the effective dose is measured in micrograms rather than milligrams, and deadly when mixed into other drugs at inconsistent concentrations. Fentanyl did not replace heroin. It contaminated the entire illicit drug supply, appearing in counterfeit pills, in cocaine, in methamphetamine, in everything. Because its potency means that a small amount goes a long way and dramatically increases the profit margin of whatever it's mixed into. The death toll from fentanyl has been staggering. The CDC has documented more than 80,000 overdose deaths per year in the United States in recent years, with synthetic opioids, primarily fentanyl, driving the majority of those deaths. That number represents more Americans dying from drug overdoses each year than died in the entire Vietnam War. It represents more deaths annually than the peak years of HIV epidemic. It is a sustained mass casualty event that has been ongoing for nearly a decade and that has touched virtually every community in the country, rural and urban, wealthy and working class, in ways that the political class has been largely unable or unwilling to address at the level of its actual cause. Cyclorophene is the next step on that curve. Where fentanyl is 50 to 100 times more potent than morphine, cyclorophene is described by experts as approximately 10 times more potent than fentanyl, meaning it's somewhere in the range of 500 to 1,000 times more potent than morphine in terms of the dose requirement to produce its effect. At that level of potency, the margin between a dose that produces the effect a user is seeking and a dose that stops their breathing is essentially zero. There is no safe recreational dose of a substance that potent when it's arriving in an unregulated supply chain mixed with other drugs at unknown concentrations. The 16 deaths in Knox County that have been attributed to cyclorophene so far all involved combinations of drugs, because that's how it arrives, mixed into other substances, and because the user had no way of knowing it was there. Dr. Schrecker's point about the mixture is the critical public health reality. People are not seeking out cyclorophene. They're buying something, a counterfeit pill, a baggie of powder represented as something else, and cyclorophene is in it without their knowledge. The overdose is not the result of someone taking too much of a drug that they knew they were taking. It's the result of someone taking a dose of something that contained a substance they did not know was present at a concentration they had no way of measuring, of a potency that they had no frame of reference for. That's not a drug use risk calculation gone wrong. It's a poisoning. Dr. Schrecker was specific about the origin of cyclorophene. It is unlikely to be manufactured in the United States. It's almost certainly being produced in countries where the substance is not regulated as illegal, and then imported into the United States through the same supply chains that have been delivering fentanyl and its precursor chemicals for the past decade. That supply chain has two primary nodes. The first is China, which has been the dominant source of synthetic opioid manufacturing for the American illicit drug market for over a decade. Chinese chemical manufacturers operate in a regulatory environment that has historically moved slowly to schedule new synthetic compounds, creating windows during which novel substances can be legally manufactured and exported before international scheduling agreements or domestic regulations catch up. The Chinese government has taken some steps under diplomatic pressure to restrict fentanyl precursor exports, but the pace of novel synthetic development, the deliberate modification of molecular structures to create new compounds that are not yet scheduled, has consistently outrun the regulatory response. Cycloraphine's presence in the American drug supply is consistent with the pattern of novel synthetic opioids developed in Chinese or analogous manufacturing environments and exported through distribution networks that use commercial shipping, mail, and the full range of legitimate logistic channels to move product. The second node is the Mexican cartels, which have built the domestic distribution infrastructure that moves synthetic opioids from their point of entry into the United States to the street-level markets where they reach users. The cartels do not primarily manufacture fentanyl. They receive precursor chemicals, often from China, and complete the synthesis in Mexican laboratories before moving the finished product across the border. The same distribution networks that move fentanyl move every novel synthetic that enters the market. When cyclorophene arrives, whether manufactured in China and imported directly, or processed in Mexico and moved across the southern border, it enters the same cartel-controlled distribution channels that have been supplying the American drug market for decades. The border is the point where policy and consequence meet. The Biden administration's 4 years of reduced border enforcement, the reduction in physical barrier construction, the reduction in Border Patrol operational capacity, the catch-and-release processing policies that moved people through the system without adequate screening, the dismantling of the agreements with Mexico and Central American countries that had reduced illegal crossings under the previous administration, created the operational environment in which the cartel distribution networks that move synthetic opioids into the United States expanded their capacity and reduced their operational risk. More people crossing means more packages crossing. More packages crossing at higher volumes means less screening per package. Less screening per package means more product getting through. The fentanyl crisis and the emerging cyclorophene crisis are not separate from the border policy failures this show is documented across multiple episodes. They are among that policy's most lethal consequences. The Tennessee Bureau of Investigation is working with local law enforcement to identify the cyclorophene supplier. The investigation is important, and the people conducting it deserve support and resources. But identifying the local supplier does not address the supply chain. Arresting the street-level distributor of a substance that's being manufactured abroad, imported through commercial shipping and border crossings, and distributed through a national cartel infrastructure does not stop the next shipment from arriving. The only intervention that addresses the supply chain at the level of its actual origin is a combination of diplomatic pressure on source countries, physical border security that increases the operational risk and the cost for cartel distribution networks, and the kind of sustained law enforcement coordination at the federal level that requires the institutional will to treat this as a national security emergency that it actually is. 16 deaths in Knox County, rising numbers in Kentucky, confirmed presence in Middle Tennessee. These are the numbers at the moment this episode is being recorded. And they will be higher by the time that you hear it, because that's how every synthetic opioid emergence has proceeded. The initial cluster of deaths is the visible edge of a much larger exposure that takes months to fully document. Behind every one of those 16 deaths is a family. A mother who got a phone call, a father who identified a body, children who will not have a parent, siblings who will spend decades with the particular grief of losing someone to the drug crisis, a grief that is complicated by the stigma that still attaches to overdose death. That makes it harder to mourn publicly. That makes people lower their voices when they explain how it happened. The stigma is one of the most cruelest aspects of the opioid crisis because it isolates the families who most need community support at the moment they most need it. Tennessee is not a state that the national media typically covers as a drug crisis epicenter. The opioid crisis in media coverage has historically been concentrated on the Rust Belt and Appalachia. West Virginia, Ohio, Kentucky, Pennsylvania, the places whose suffering was visible enough and concentrated enough that it eventually broke through the media's general indifference to rural, white, working class pain. Tennessee has been living its own version of that crisis for years, with Knox County and the surrounding region showing some of the highest overdose rates in the state. The introduction of cyclorphine into that already stressed environment, into communities that have been managing fentanyl's devastation for years, where first responders are trained for naloxone administration, where every emergency department has protocols for overdose treatment, introduces a variable that the existing response infrastructure is not yet calibrated for. Dr. Schrecker's uncertainty about how many doses of Narcan a cyclorphine overdose requires is the specific clinical gap that makes this drug so dangerous in the immediate term. Naloxone works by displacing opioids from the receptors in the brain and the brainstem that control breathing. For a standard fentanyl overdose, 2 or 3 doses of Narcan administered properly will typically reverse the respiratory depression and restore normal breathing. For a drug 10 times more potent than fentanyl, the receptor binding may be stronger and more persistent, potentially requiring more doses to achieve the same reversal. And if that first responder doesn't know that, if they administer the standard protocol and see initial improvement followed by a relapse, the outcome may be fatal before the situation is recognized and additional doses administered. Training first responders on cyclorphine-specific protocols requires knowing what those protocols are, and the drug is too new for that knowledge to exist at the level of certainty that emergency response requires. The families in Knox County and the counties around it are not abstract policy stakeholders. They are the people whose sons and daughters and spouses and parents are dying from a drug that was manufactured somewhere outside this country, imported through supply chains that the federal government's enforcement apparatus should be disrupting more effectively than it is, distributed through cartel networks whose operational capacity expanded during 4 years of reduced border enforcement, and mixed into a drug supply that delivers it to users who have no way of knowing that it's there. Every element of that chain is a policy failure with an address. Every one of those 16 deaths is the consequence of choices made by people in positions of authority who chose not to secure the border, not to maintain the diplomatic pressure on source countries, not to fund the enforcement infrastructure that would have made the supply chain more expensive and more dangerous for the people running it. The Tennessee Bureau of Investigation is doing its job. Local law enforcement in Knox County is doing its job. The clinicians at Aegis Sciences Corporation are doing their job. Testing, identifying, warning, publishing their findings through the media channels that will reach the communities at risk. The first responders who carry Narcan and administer it to the people who are dying in front of them are doing their job, even without the protocol certainty that a well-characterized drug would give them. The institutional response at the local and state level is functioning within its capacity. The federal response is the gap, and the gap is not primarily a resource gap. It's a policy gap. The resources exist. The DEA has the authority and the operational capacity to pursue synthetic opioid supply chains at the federal level. The State Department has the diplomatic tools to apply pressure on source countries. The Department of Homeland Security has the legal authority and the operational capability to interdict drug shipments at points of entry and to work with the Mexican government on cartel interdiction. What determines whether those tools are used at maximum effectiveness is the policy commitment of the administration and the institutional culture of the agencies deploying them. The Trump administration has demonstrated a policy commitment to using those tools more aggressively than its predecessor. The fentanyl designation as a national emergency, the tariff pressure on China and Mexico tied explicitly to fentanyl precursor exports, the restoration of border enforcement infrastructure that increases operational costs for cartel distribution networks. These are the right policy directions. They require sustained political will and institutional follow-through to translate into the supply chain disruptors that would actually reduce the flow of cyclorophene and whatever synthetic opioid comes after it into American communities. The demand side of this equation belongs in any honest accounting, and this show will not pretend otherwise. The synthetic opioid crisis exists because there's a market for it, because millions of Americans are in enough pain, physical or psychological, that they're seeking chemical relief in the illicit drug supply, often after pathways to legal pharmaceutical treatment were closed off or were never accessible to begin with. The treatment infrastructure, the addiction medicine capacity, the recovery support systems, the community-based resources that help people through withdrawal and into sustained sobriety is underfunded in most of the communities most affected by opioid crisis. Rural Tennessee does not have the same density of treatment options as urban Nashville. That disparity is a policy failure with consequences measured in deaths, and it belongs in the same conversation as the supply chain failures. But the supply side is where the most immediate policy levers are. And it's where a border argument is most directly relevant. A drug that is manufactured abroad, imported through the same distribution infrastructure that has been delivering fentanyl for a decade, and mixed into the street drug supply at concentrations that make it impossible for users to know what they're taking. That drug's presence in Knox County is not primarily a Tennessee problem or a local law enforcement problem. It is a national security problem with an international supply chain and a domestic distribution network that has been allowed to operate at increasing capacity during a period of reduced federal enforcement commitment. The 16 families in Knox County deserve an answer to the question of how the drug that killed their family member got to Tennessee. The answer starts at the southern border and runs through a cartel distribution network that 4 years of open border policy helped expand. 16 people are dead in Knox County, Tennessee, from a drug 10 times more potent than fentanyl. Kentucky is reporting rising overdose deaths linked to the same substance. Middle Tennessee has confirmed cases. The drug is manufactured abroad, imported through the existing synthetic opioid supply chain, and mixed into street drugs without the knowledge of the people who buy them. Narcan can reverse an overdose, but nobody yet knows how many doses it takes. The Tennessee Bureau of Investigation is working to identify the local supplier. That work matters and should be resourced. But the local supplier is the last link in the chain that starts in a foreign manufacturing facility, crosses an international border, moves through a cartel distribution network, and ends in Knox County. Arresting the last link does not close the chain. It requires policy action at every point where the chain can be disrupted. Diplomatic, enforcement, border security, and treatment. Applied with the sustained political will that this administration has shown more of than its predecessor, and it needs to maintain. The families behind the 16 deaths deserve that sustained commitment. The communities in Tennessee and Kentucky that are watching this drug spread deserve it. The first responders who are administering Narcan without knowing how many doses they need deserve the research and protocol clarity that will come only if the clinical community has the resources and the urgency to characterize this drug as quickly as the death toll demands. Pray for the families. Support your local first responders. Know where the Narcan is in your community and know how to use it. And do not let the political class that opened the border and reduce the enforcement capacity that would have made this supply chain more difficult to operate, escape accountability for the consequences of those choices. 16 families in Knox County are living those consequences right now. Stand with us, support the mission, refuse the silence. Find us at titdusa.com and the Stand Against the Silence campaign. I'll see you next time. God bless.